Hello friends, today I am going to reveal some true facts of maturity onset diabetes of the young, MODY. But first of all, I request you to please share and subscribe my channel for getting my informative true facts videos uninterrupted. Please note that subscription of my channel is free of cost. Now, maturity onset diabetes of the young, MODY, refers to any of the several hereditary terms of diabetes mellitus caused by mutations in an autosomal dominant genes disrupting insulin production. MODY is often referred to as a monogenic diabetes. To distinguish it from the more common type of diabetes, especially type 1 and type 2, which involve more complex combinations of causes involving multiple genes and environmental factors. MODY 2 and MODY 3. Maturity onset diabetes of the young 2 and 3 are the most common forms. MODY should not be confused with latent or autoimmune diabetes of adults, LADA, a form of type 1 diabetes mellitus, with slower progressions to insulin dependence than child onset type 1 DM, and which occurs later in life. History of the concept and treatment of maturity onset diabetes of the young, that is MODY. The term MODY dates back to 1964, when diabetes mellitus was considered to have two main forms: juvenile onset and maturity onset, which roughly corresponds to what we now call type 1 and type 2. MODY was originally applied to any child or young adult who had persistent asymptomatic hyperglycemia without progression to diabetic ketosis or ketoacidosis. In respects, we can now recognize that this category covered a heterogeneous collection of disorders which included cause of dominantly inherited diabetes, the topic of the article is still called MODY today, as well as the case of what we could now call type 2 diabetes occurring in childhood or adolescence, and a few even rare types of hyperglycemia, that is mitochondrial diabetes and mutant insulin. Many of these patients were treated with sulfonalirones and various degrees of successes. And the current usage of the term MODY dates for a case reports published in 1974. Since the 1990s, the understanding of the pathophysiology of diabetes have improved. The concept and the usage of MODY has become refined and narrower. It is now used as a synonym and dominantly inherited monogenic defects of insulin secretion occurring at any age, and no longer includes any form of type 2 diabetes. Signs, symptoms and differential diagnosis. Currently, MODY is the final diagnosis in 1% to 2% of people initially diagnosed with diabetes. The prevalence is 70 to 110 per million people. 50% of first degree relatives will inherit the same mutation, giving them a greater than 95% lifetime risk of developing MODY themselves. For this reason, correct diagnosis of this condition is important. Typically, patients present with a strong family history of diabetes, any type, at the onset of symptoms is in the second to the fifth decade. There are two general types of clinical presentation. Some forms of MODY produce significant hyperglycemia, and the typical signs and symptoms of diabetes increased thirst and urination, polydipsia and polyuria. In contrast, many people of the MODY have no signs or symptoms and are diagnosed either by accident when high glucose is discovered during testing for other reason, or screening of relatives of a person discovered to have diabetes. Discovery of mild hypoglycemia during a routine glucose tolerance test for pregnancy is particularly characteristic. MODY causes make up as many as 5% of presumed type 1 and type 2 diabetes cases in a large clinic population, while the goals of diabetes management are the same no matter what type. There are two primary advantages of confirming a diagnosis of MODY. Insulin may not be necessary, and it may be possible to switch a person from insulin injections to oral agents without loss of glycemic control. It may prompt screening of relatives and so help identify other cases in family members. As it occurs infrequently, many cases of MODY are initially assumed to be more common forms of diabetes. Type 1 of the patient is younger, not overweight. Type 2 of the patient is overweight or gestational diabetes. If the patient is pregnant, standard diabetes treatment, insulin for type 1 and gestational diabetes and oral hypoglycemic agents for type 2 are often initiated before the doctors suspect more unusual forms of diabetes. Treatment. In some forms of MODY, standards treatment is appropriate through exceptions occurs. In MODY 2, oral agents are relatively ineffective. However, most patients are managed conservatively through diet and exercise. In MODY 1 and MODY 3, sulfonylureas and is very effective, delaying the need for insulin treatment. Presentation. The following characteristics suggest the possibility of a diagnosis of MODY in hypoglycemic and diabetic patients. Mild to moderate hyperglycemia, typically 130 to 250 milligram and 7 to 14 discovered before 30 years of age, or anyone under 50 can develop MODY. A first degree relatively with a similar degree of diabetes. Absence of positive antibodies or other autoimmunity, that is thyroiditis and patients and family. However, Urbanova found about 1/4 of Central European MODY patients and positive isolate of autoantibodies, GADA and IA2. Expression is transient but highly prevalent. Insulin resistance very rarely happens. Cystic kidney disease in patients to close relatives. The recognized forms of MODY are all due to effective insulin productions or increased pancreatic beta cells. Several of the defects are mutations of transcription factors genes. One form is due to the mutation of the glucokinase gene. For each of forms of MODY, multiple specific mutations, different amino acids substitute have been discovered. In some cases, there are significant differences in the activity and the mutant gene product that contribute to variations to the clinical features of the diabetes, such as the degrees of insulin deficiency or age of onset. Genetics. Some sources make a distinction between the two forms of monogenic diabetes, MODY and neonatal diabetes. However, they have much in common and are often studied together. Homozygous. In deficiencies in forms of MODY are autosomal dominant requires only one abnormal genes to produce the disease. The severity of the disease is moderated by the presence of a second normal allele which presumably functions normally. However, conditions involving people carrying two abnormal alleles have been identified. Unsurprisingly, combined homogeneous defects of the genes are much rarer and much more severe in their effects. MODY 2, homozygous glucokinase deficiency causes several congenital insulin deficiency, resulting in persistent neonatal diabetes mellitus. About 6% have been reported worldwide or have required insulin treatment from shortly after birth. The condition does not seem to improve the age. In my next video, I will reveal some true facts of other more interesting topics. Thanks.